then this entire assembly is going to be dissociated. It is not connected to the axial skeleton and it is kept floating in the arm, and that is why it has gained its name, that is floating shoulder. So hope you have understood everything related to this topic in particular. So answer obviously is the fracture neck of humerus. That is the answer for this particular question, because it is not the requirement, it is not the component of this condition. So now you already understood that why this floating shoulder is needed to be fixed. You know, if the patient is presenting to you with a floating shoulder, the entire assembly is dissociated with the axial skeleton, then it need to be fixed, and that is the reason why it was kept among this option, or this indication was kept among the surgical fixation. Hope everything is clear related to this topic in particular. That means the fractures of the clavicle and fractures of the associated fractures of the clavicle. Now, next question. First of all, before we talk about this topic, it is important to have a discussion on this question itself. Question is, what is the name of the nerve which is likely to get injured associated with the fracture which is provided to you in the X-ray? Now, if you look closely at the X-rays, now here what you are having, this is clavicular bone, this is the glenoid region, and this is the humerus. Now, here we are having the fracture of the proximal humerus in the neck region. So, it is obviously the fracture neck of humerus. And the name of the nerve which is lying in approximation to the proximal part of the humerus is the axillary nerve. You know, every time the examiner gives you this question, he wants to ask you what is the name of the nerve which is likely to get injured associated with this fracture. Alright. So, let's talk about this fractures of the proximal humerus. Now, point number 1, what is the name of classification? The name of classification is Neer classification, N-E-E-R, simple. Now, is it important to have a discussion on the 4 different types of Neer classification, because it is further classified into 4 different types? Then answer is obviously no. Alright? No, it is not at all important to have a discussion on the 4 different types. Why? Because if there is a fracture of the humerus, imagine if this is the proximal part of the humerus bone, and there is a fracture in the proximal part of the humerus, then how the Neer has classified it, type 1 is 2-part fracture. Then type 2 is 3-part fracture. There will be associated of 3rd part. Then type 4 is, so simply means with the addition of the fracture line, one type of the fracture is getting added in the list according to Neer classification. So no question is going to be framed on what exactly Neer classification is. Alright. But what you have to understand is just the name. Remember the name, Neer classification. Yes. What is the Neer criteria for displacement? Now, this is something which is important for you to understand. Now, as far as this Neer criteria is concerned, for displacement, there are 2 components of this Neer criteria. One is that there has to be an angulation of more than or equal to 45 degrees in between the 2 fragments. Point number 2, that the displacement at the site of the fracture has to be almost up to 1 centimeters. Then it becomes the criteria that the fracture is said to be displaced fracture. Just take an example. For example, if this is the humerus bone, alright, and here we are having the fracture of the proximal part of the humerus. Alright. Now, after getting fractured, imagine this bone got fractured, and after getting fractured, the 2 fragments are displaced like this. Now, if the distance, the maximum distance in between the 2 is less than 1 centimeter or is equal to 1 centimeter, means more than or equal to 1 centimeter, it is considered to be a displaced fragment. That is point number 1. Second is that if the angulation in between the 2 fragment is found to be up to 45 degree, then it is said to be a displaced fragment. Alright. So, this is the Neer criteria for the fractures to be called as a displaced fracture. Now, what is the prognosis or what is the importance of this Neer criteria? You know, what is the importance of having this displacement? Because the importance is that it is responsible for estimating the prognosis. That means it is responsible for estimating the outcome of these kind of fractures. Imagine if there is too much of displacement, then the outcome is going to be poorer. The outcome is going to be difficult. Alright, for that particular fracture. So, it is needed to be fixed in its anatomical position to have a lesser complication out of it. Then point number 3 is obvious answer for you, that what is the most common nerve injury? It is the axillary nerve, which is the most common nerve. And you know, examiner tends to ask you this question again and again, but you should always remember that when the patient presents with the fractures of the proximal humerus, there has to be the assessment of axillary nerve integration. Alright, that you have to check for the abduction, although he won't be able to abduct the arm because of the fresh fracture, And second is, you have to look for the sensations in this region, regimental badge sign, you already are aware of. And finally comes the complication part. Now you tell me, it is not difficult to understand the complications. Point number one, shoulder being the most mobile joint, if at all there is a fracture around this bone, then it is going to have the impairment of the movement of this. So the most common complication associated with the fractures of the proximal humerus is the stiffness. Whether you operate upon the patient or you don't manage the fracture surgically, there has to be a stiffness associated with this. Point number two is a complication related to union. Now you tell me, it is not very difficult to understand. Now this is the proximal part of the humerus. This is the proximal part of the humerus, all right? Now this proximal part of the humerus is a cancellous region of the bone. It is the cancellous region of the bone. And being the cancellous bone, it is going to be more porous. Because it is more porous, it will be more vascular associated. There will be more vascularity. And once the region in which the fracture has happened is more vascular, is more porous, the chances of union are higher. So, if at all you have to decide to write the complication related to the union, you are having two options. One is non-union, other one is malunion. So, obviously you have to go with the malunion. That means union will happen, but it is not going to happen in a correct manner. It will unite in an improper fashion. So, malunion is a common complication associated with this fractures of the proximal humerus. So, hope everything is clear related to this topic in particular. What we have talked about, one, the name of classification, second, the criteria and its importance, and the third one is the most common nerve injury associated with this, and finally the fourth one is the complications. The most common complication is found to be the stiffness associated with malunion. Now, here what we are having, there are two types of method for the management of this particular patient. One is conservative. Obviously, the conservative, what you have to go for, there has to be the application of a U slab. All right. Now, this is how the slab is applied. There will be a U slab applied. So, conservative method, you have to go with the U slab. While surgical method is obviously the opening up of the fracture, and in the anatomical reduction, you have to go for open reduction internal fixation using a pre-contoured proximal humerus locking plate. All right. So, this is how the surgical fixation is achieved in the proximal end of the humerus. Now, this is something which is important for you, because again and again they used to ask this question, that what is the name of the nerve which is likely to get injured with this particular fracture. All right. Now, till this point, what we have already discussed, we have talked about the shoulder dislocation, and we have found the axillary nerve is most common nerve to get injured associated with this. We have already talked about. Then fracture of the proximal humerus, we have talked about the axillary nerve. So this is the kind of the table which is going to be repeated again and again. So at this point of time itself, you have to revise it and learn it, so that in future it becomes much easier for you to answer these questions accordingly. But there is nothing which you need to mug up, because associated with the fracture, only the nerve which is just associated with this bone is going to be injured most commonly, and around the shoulder it is always the axillary nerve that you have to remember for that particular case. Next is the fractures of the clavicle. In the upper limb trauma, the most commonly fractured bone which is seen in day-to-day practice is the fractures of the clavicle, because the same reason, fall on outstretched hand, when the force is subjected and it is passed all the way up to the clavicle, then it will result in the breakdown of this bone into two of its component. All right. So, fractures of the clavicle. Before we talk anything related to the clavicular fracture, it is important to have a discussion on some unique, peculiar features to the clavicle, which is anatomic. Like point number one, what are those unique features of the clavicle? That it is the only horizontal long bone. All the long bones are vertically aligned. This is the only long bone which is horizontally aligned. Point number two, that it is the only long bone which ossifies by intramembranous ossification. All the other long bones of the human body, they ossifies by enchondral ossification. But this is the only long bone which ossifies by intramembranous ossification. Point number three, you should be able to understand what is intramembranous, what is enchondral ossification. Like if there is a cartilaginous laying of the layers, over to that, if the bony components are getting integrated, then this is known as intramembranous ossification. All right. Point number three, that it is the only long bone without marrow means there is no marrow cavity. So this is the only long bone which is not having any marrow cavity. All right. So these are the unique features of the clavicular bone, and this is also a long bone which has got two primary ossification center and a single secondary ossification center. So it is the only long bone which has two primary ossification and one secondary ossification centers. All right. So these are some of the peculiar features of this clavicular bone. Now let's talk about the fractures of the clavicle in particular. Now, as far as this fracture of the clavicle is concerned, we are not going to have a discussion on what is the mechanism of injury. It remains the same. More importantly, or most importantly, the point is that what is the most common type of the fracture? Means what is the most common location in which this fracture of the clavicle happens. So it is at the junction of medial 2/3 and lateral 1/3. So that is a junction of the medial 2/3 and the lateral 1/3 is the most common site where these fractures happen. Now imagine if the examiner is not interested in asking about the junctions, he is just interested in asking about whether it is happening in the medial, in the middle part or in the lateral part. So in that case, you have to write down the middle part. All right. So in the middle 1/3 of the clavicle, this is the most common site. But if the question language is asking about the junctions, then medial 2/3 and the lateral 1/3 is the most common site at the junction of this, where the fractures of the clavicle happens. Now, as far as the treatment is concerned, now the treatment more commonly, almost 95% of the fractures of the clavicle are managed conservatively. So conservative only. You can give elbow pouch. You can use figure of 8. All right. So figure of 8 slings can be used for the immobilization, or simple elbow pouch, arm pouch can be used for immobilization of the upper limb, so that the condition is rendered less painful. Over a period of time, this clavicular fractures will unite. Now this is conservative. Now as far as the surgical methods of fixations are required, surgery, that means fixation, is required only in several indications, and those indications are also relative. There is no such absolute indication for the management of the clavicular fractures by surgical fixation. So what are those relative indications? That if there is a displacement, of more than 2 centimeters, that is one of the relative indication. Then point number 2 is that if there is a neurovascular injury. Point number 3, based on the patient's consent, that if the patient is giving a consent that I want to get it fixed by surgical means, so if the patient is interested, all right, so these are considered to be the relative indications for the fractures of the clavicle, and if it is associated with the floating shoulder. Floating shoulder means there are associated fractures of the scapula also. All right, we will come to have a discussion on what the floating shoulder is. So these are the relative indications. Now, as far as the complications are concerned for the fractures of the clavicular bone, every time they ask you about the clavicular fracture, then most common thing which is likely to happen with this clavicular fracture are the complications. You see, when we have talked about the clavicular fracture, like this is the clavicular fracture, and it can be managed by either a sling in a figure of 8 pattern or the elbow pouch which could be provided, all right, just for the purpose of immobilization for the period of around 3 weeks to 5 weeks. But this surgical method of fixation is required with the relative indications. Now imagine if the patient is not managed surgically, then it will lead to several complications. So what are the complications? The most common complication which is found to be associated with the clavicular fracture is the malunion. It is the malunion, because imagine if this is the fracture of the clavicle and it is left to be united by itself, then it will lead to a malunion kind of the fixed union at the fracture site. All right. So the fractures are going to be malunited, as a result of which what you will see is a bump.